When I was practicing in Vancouver, and I was recruited to McMaster University, and so that's the next disclaimer, is that don't get any real estate advice from me, because I moved in 2000 just when the real estate prices in Vancouver went like that, and we didn't keep our house. But when we moved to McMaster, that was my impression of Hamilton, and that's probably your impression of Hamilton. And you're right, that is what Hamilton looks like. But if you just reframe your vision slightly and look at it maybe in a slightly different way, you might actually change your vision of what Hamilton looks like. And this is my message for you in terms of our healthcare system. It is a matter of reframing it. It's evolving how we're thinking about it. It's not revolutionizing it. My wife, I always knew she was 1 in a million, but I found out that she was 1 in sort of 50 million. She had a right coronary artery that took off from the left side and tunneled through the aorta and twisted around between the aortic arch, and I mean, I can't even remember the complicated anatomy. And she spent, about 3 years ago, she spent 3 weeks in the UHN in Toronto, because even though Hamilton does thousands of open heart surgeries a year, she was much too complicated for Hamilton. And I got a true taste of just what it's like in our acute care system and how well we take care of critically ill patients. And as a result of that, she's doing really well. But what the challenge was when we moved from the acute care system into the primary care system, and just what that bridge is. And we've spent a lot of time and energy in Ontario creating a pretty strong Ontario health hospital system and a pretty strong primary care system. And we've built this really rickety bridge, which we shoot the patients out from either system and hope they don't fall into the chasm on either side. And that really is what I'd like to talk about today, is how we create an integrated system. We in Ontario have moved away from the fee-for-service model into the more bundled, not bundled care, out of into an alternate payment plan, and in more of a capitated model. And you'll note that it says that 71% in 2013 are in a I keep saying that, into a non-fee-for-service model. It's actually up into the 90s now. But when you look at what our outcomes are, we're no better in Ontario than you are in Alberta, and you've seen some of the slides already. And yet, when we talk about ourselves moving to a capitated model, in fact, it's 48% of Canadians, physicians, say that they provide access for after-hours care. We know in Ontario that 90% of us are on some sort of model where we've signed a contract saying that we'll provide after-hours care, and yet it's even worse in Ontario. It's about 40% of us actually provide. This is self-reported physician information to the Commonwealth Fund, and yet that's a bit of a disconnect, isn't it? 85% of us or 90% of us have signed a contract providing after-hours care, and yet when we're surveyed by the Commonwealth Fund, 40 to 50% of us actually say that we do provide it. So how is it that we create the accountability for ourselves? In the 1840s, this is the Sea Witch, which is a ship that was an American clipper that was built by a bunch of New York merchants and a bunch of New York tea merchants. And in those days, the number of ships that were going down in the Hong Kong to New York route was substantial, and they were losing money. The costs went up, and they got together and created what is called the Sea Witch. And it was an American clipper ship built in the 1840s. In 1849, it went from Hong Kong to New York City in 74 days, which was a record that stood until 2013, when it was beaten finally by a specialty-built ship. And the important message here is they took what was a broken system. It was complicated. It it required teamwork, it required forward thinking, and they created a model that worked, and it worked and stood the test of time. We have done exactly the opposite in our primary care system. We've taken a complicated, complex system that requires thoughtful process, and this is what we've come up with. And then what we've done is we've said, okay, let's create a bunch of pilots. We'll take this rowboat and we'll add a mast and maybe a pontoon and do things. And we've sort of jury-rigged as opposed to saying, let's start to create a system that is going to be purpose-built for what our problems are in our society. Susan Fitzpatrick was the Senior Associate Deputy Minister of Health in Ontario in the last 10 years. And in 2013, she commissioned us to create a primary care expert advisory committee. And it was made up of a whole bunch of primary care experts from all walks of life, importantly, none of whom represented specific organizations. All were acknowledged experts in their field, but none were actually representing organizations. And we had an incredible group that got together. And we were asked by the ministry to address 4 key issues. That patients had a regular provider. In other words, they had access to a family physician or nurse practitioner, that they had access to after-hours care, that they were part of an interprofessional team, and of course, the really easy one is that the system was horizontally and vertically integrated, and that's a really simple question for us to answer. And our committee got together and we started addressing this, and on our first day we recognized this is what we always do in healthcare in this country, is we take those 4 isolated problems and we try to address them individually. And this is what happens. We create a whack-a-mole. And this is probably not politically correct anymore, but certainly this was a game for those of us who grew up in the 70s. And the concept here is you hit the mole in one place and it pops up somewhere else. And this is the inadvertent consequence. If you just focus on access of one thing, you then create downstream problems. So we came up with what we called patient care groups, a new model, and these words are important, population-based primary health care for Ontario. And I want to unpack each of those various concepts. It's important as well to remember the concept of equality doesn't necessarily equal equity. And this was important. This was an important concept for us as we went around. So it wasn't about equal care and equal investments. There are those, to the question that you asked earlier, who require way more intense investments from the social determinants of health than others do. And I come from Hamilton, where we have a huge inequity problem. In downtown Hamilton, your longevity is about age 58. 4 kilometers away in Ancaster, it's 85. 4 kilometers, and we have almost a 30-year difference in lifespan. How can that be in Canada in 2016? And it's getting worse, it's not getting better. So we were talking about how do we create an equitable system? And I wish we'd actually had David Naylor's group's innovation panel because we actually addressed inadvertently all of these issues, perhaps with the exception of industry. And as we go through, I want to just highlight some of these areas that were really about unleashing innovation. So we created what we called patient care groups. And we talked about geographic rostering, and we nominally took about 100,000 patients. So we said that this community should be a population of about 100,000 patients, and that's based on evidence from around the world, and I can unpack that for you if you want. But essentially it meant that the patient care group was a community that was responsible for those 100,000 patients. In whatever model you want, it doesn't really matter, but that you are a most responsible organization for those 100,000 patients. And one of the concepts for us that I've never understood in Canada is in our school systems, if you are a student and you move to a community, we'll provide school for you. We'll add students to the classroom, we'll put out a portable, we'll figure it out. How on earth is it in our society you can move to a new community and be told, sorry, there's no family doctor here for you. Oh, we can't actually give you access to care. And even one of my staff, her son moved to a more rural community in Ontario with an 18-month and hasn't been able to get vaccinations. And he's phoned every single primary care clinic within a 40-minute drive of his new town, and he can't find anybody who will give his child a vaccination. So they came down over Christmas and someone in my office gave the vaccination. So this is the challenge for us, is to create the kind of responsible organization where when you move into that community, there is an organization that says, yeah, we'll take care of you, we'll figure it out, and the physicians have to be a part of that. And that's where that next is local governance, physician leadership. Not necessary that the physicians have to be the leader, but they have to be part of the leadership group. And that is the other message that I would give to you as you're starting to think about how you evolve your system here. When we looked at jurisdictions around the world, in Australia is perhaps the first example of this, they created what they called, we'll call them physician networks or patient care networks, but they didn't involve physicians on the leadership. And they soon realized that they needed to transform the system to engage physicians. And it's clear that if you don't engage physicians as part of the physician leadership in these organizations, you're doomed to failure. But it's also true that there needs to be a governance system, and it needs to be integrated with your public health, with your various community services. And that was really the next part of it, was that it's a public health partnership with a population-based needs assessment so that we understand what is our community and what do they need and what matters to our community of patients and how do we supply the resources to that group of patients. And what you're going to need in downtown Calgary or downtown Edmonton is going to be very different than what you're going to need in the rural area, and it's going to be very different between the various socioeconomic groups. And how is it that you create the environment where you as physicians and you as a health leadership can figure out what is important in that area. Ontario is moving towards a team-based environment in primary care. We have about 25% of our population have access to allied health professionals, physiotherapists, pharmacists, nurse practitioners, social workers, mental health workers, system navigators, et cetera, et cetera. But therein lies the inequity of the system that we've developed. We've actually inadvertently in Ontario developed a two-tiered system. 25% of our patients have access to allied health professionals, 75% do not. And it's purely by luck of the draw where you live and where you and who your physician is. And if your physician happens to be in a model that provides after hours access to care, you get after hours access. And if you're unlucky enough and your physician has a machine that says it's now 5 o'clock and the office is closed, we'll reopen a week Tuesday, and in the meantime go to your local emergency, you don't have access to after hours care. So it's how do we figure out an equitable across-the-board system. And for us, the allied health resources should be based on needs in the community and needs of that particular population as opposed to a numbers base. So in our particular practice, we have a number of nurse practitioners, social workers based on our number of patients. There's a formula and we get it, whether we need it or we don't. And it depends on the community that you're in as to what you should be able to tweak it. IT in our paper was really an effective way of delivering accountability, quality, and outcomes. Our paper in the patient care group talks about quality outcomes as being set perhaps by the government or by Health Quality Ontario, it doesn't matter who sets it, and then you locally figure out how to deliver those quality outcomes. but you also need to know your own patients and your own patient population to know what the important quality outcome that you want to measure and you want to try and address. So in our own practice at the maternity center in downtown Hamilton, which cares for a high degree of lower socioeconomic and higher mental health, etc., our smoking rate is almost 40%. It's about 36% of our young women are smoking at least a pack a day when they come into our clinic. So our quality improvement metric is how do we get them to drop their amount of smoking in that group, which is a very different conversation with my colleagues in Ancaster, which is that community 4 kilometers away, where the smoking rate is less than 10%, and it's around 5% in their pregnant women. So how do we use our IT systems to do that? The Commonwealth Fund talks about the IT being critical as well, the Commonwealth Fund, and talks about only less than 20% of our practices can electronically exchange patient clinical summaries with doctors outside the practice. We were at dinner last night and I was recounting the story that I'm notified 100% of the time about my patients who enter into the emergency via a fax that comes to my office. And I would say 98% of the time I can't read it because it's written in handwriting and it's completely illegible, which means that I actually don't know whether this is something I need to follow up on or not, and have to go to other means to try and access the resources. So it's information that's legible, that's logical, that makes sense. And the other thing that astounded me in the Commonwealth Fund is that 15% of our patients can email about a question or a concern. And that is partly driven by our models of remuneration. If you're in a fee-for-service model where you only get paid for seeing your patient, you're not going to do a lot of phone calls or emails or anything else. And that was certainly the system that I was working in Vancouver. In our system in Ontario, and certainly in the practice that I work, we actually encourage this kind of communication because it makes a big difference to our patients and it allows us for a more holistic, and I get paid equally whether I see the patient personally or whether I communicate them via email. So we're lucky enough that we have an open source system called OSCAR, and it's one of many EMRs that are certified in Ontario. And what we're moving towards in Ontario is trying to ensure that our systems then can talk to one another, so that we do have a finite number of EMRs that are certified, that allow for quality outcomes. We know about their safety and security, but we really need to move towards being able to be interoperable. Kindred PHR, for example, is our personal health record that we've developed at McMaster that links to EMRs. So to give you an example, this morning when I got up, I went on to my EMR, and I'm able to look at the lab work that's come in, and I'm able to acknowledge it and file it, or I can acknowledge it and send it to my patient with a little note that says, you're doing great, or we don't need to treat your symptoms because it turned out to be viral, or whatever it is, and the patient gets it at almost the same time I do. The patient also using this personal health record is able to access their immunization records, recent consults from the specialist, all of those sort of concepts. It's starting to move us into the 21st century, and we are actually behind, I think, in terms of some of the electronic solutions that are needed. One brief word about another project that we're doing, which is called Health Tapestry. We actually have a partnership here in Edmonton with the University of Alberta, and my colleague Charles Leduc, who's here, will be aware of this, and coincidentally it's in Rona Ambrose's riding, but I'm not sure that. I think that was a coincidence as opposed to planned, although she was the Minister of Health when we started it. But this is a partnership across the country of a number of different sites, including a First Nations community. We're also in Vancouver and Newfoundland. But what the concept here is, it's around volunteers going into patients' homes using what we call a TAP app, which is a new electronic system to go, an older volunteer partnered with they call themselves mature volunteers, partnered with a university or college-age student, going into the patient's home and understanding what is important to those patients. And I must admit, when they went and saw one of my patients who was a couple in their 70s, I've looked after them for at least 15 years. I've looked after their children. I've actually delivered their grandchildren. And I was shocked when the TAP report came back, the Tapestry report came back to us, because it identified some things that I actually didn't know about my patients, even though I thought I knew the family really well. And interestingly, one of the things that came out of it was that the husband was falling, and our stats would say that 33% of our so-called healthy older patients have falls. And the other thing was that almost half of our patients wanted to talk about advanced care planning, in other words, end-of-life planning. And so we actually created out of that groups where we bring in some of our older patients and we allow them to talk about advanced care planning, and we do it in a facilitated environment obviously with the peers, and then they come and talk to us as physicians at the end of the day. It's actually saving us a lot of money, and we're addressing what the patients are telling us within their communities that they want. Our approach really is trying to understand, using the trained volunteers, information technology, community engagement, and the interprofessional teams to really understand what matters to the patient and then target our care to those patients. So what I've tried to present is that when we, as patient care groups, we recognize that having these 4 buckets that we were supposed to address, if we didn't create an overarching vision for primary care, an overall direction for where we were going, we were doomed to failure. And this, I think, is the message that you've been hearing overall resoundingly this morning. And as always, when I come to these kind of events, I learn, I think, way more than I actually impart. So thank you for allowing me to be a part of your day. But the message really is that we have to create a vision for ourselves in primary care, which is integrated into our secondary care system and our tertiary care system. It has to be integrated horizontally out into the community, into public health, into housing, all of those areas. But we failed in our work so far. We have these poor outcomes because we have not created the overarching vision of where we want to go and where we want to end up. And to me, that is our biggest challenge. And that is your opportunity, I think, to echo David Naylor's comments. Out of crisis comes opportunity. You have the small enough population, and if Andre Picard had let me answer the question this morning about what it is that you do well here, my sense is that you're actually a fairly cohesive province, and you're not marching off in 25 different directions. Now, maybe that's a naive impression from an outsider, but it seems to me you've got that opportunity to create that model of care and actually start to work towards something, and then course correct as you go, as opposed to doing a pilot here and a pilot there. Set your flag, and in the future, start to move towards it. And that is what we've tried to do in Ontario, and as we've moved towards the Patient's First document that was released by the Minister of Health in December, that is creating the model for us. So at the end of the day, our vision from our group was that within 3 years, and we wanted to be provocative, every Ontarian will identify with a primary care provider from whom he or she receives high-quality care, which will be timely, which talks about the access, person-centered and community-based, which talks about the public health relationships, comprehensive and coordinated, which talks about the vertical integration with our hospital partners and our specialists, of good value both financially and in terms of health outcomes, and interprofessional and team-based. So that's our nirvana that we're working for. Do you remember that original photograph that I took of the steel mills? This is exactly, I'm standing on exactly the same spot. All I've turned is 180. So hopefully that's reframed your vision of Hamilton ever so slightly. Thank you.
So we have time for a couple of questions for David. Just I'll ask while the people are walking to the mic. Can you, I know that the price report or the report on the patient care groups came out, I think, in April of 2015. Do you have a sense that you've stated a vision for 3 years from now? What's happening in the political churn around discussing it?
What's happening in the real world context?
Yeah.
Well, the good news is that the report hasn't been shelved. The good news is that many of the principles that we articulated, without perhaps all of the details, are being integrated into the patient's first document, which is now out for feedback from various stakeholders, the public, et cetera. And the minister has committed to introducing legislation at the legislature in late March, early April, to try and actually move Ontario towards a more integrated system.
And I know that we do have some people who are here are parts of groups that represent patient views, citizens engaged in healthcare. So in the Q&A, I'd just like to plant the seed. It would be good for us to come back to the patient-centered nature of the vision that you painted.
And that was the whole concept around being at a community level. And you might, in a city of 500,000 people, have 5 patient care groups, and they would be responsive to the community, absolutely.
Dennis Kendall from SaskDocs in Saskatchewan. So David, I understand, there's 4 or 5 different versions of primary care teams in Ontario with various acronyms. Can you just quickly explain how does rostering work in the teams that are optimally supported by a variety of other health personnel? Is there a particular formula that says, you get this much funding for rostering when you have a team as opposed to a non-team? And then the second question is, I've heard, maybe wrongly, from colleagues or friends in Ontario that in at least one of the models, there's no cap on how many patients a doc can roster, and some docs roster more patients than they can quite reasonably attend to. Is that true? And if so, how is that being dealt with?
Right. So the first, how are patients rostered? So very simply, they sign up with me, for example. I commit to caring for them if they go and see a physician elsewhere outside of our group. There is a negation for me personally. So if they go to a walk-in clinic, if they go to another family physician in the community, there's a negation. So that's where we're talking now about the social contract between the patients and the providers, that we have to provide the services, and they hopefully will avail themselves of those services and not go elsewhere. I'm paid a capitated amount per year for that patient, which is then paid monthly. It is based nominally on age and sex. There are some acuity modifiers. There is an acuity modifier in the Kaiser Permanente, which is extremely complicated but apparently very effective. Ontario has been looking at it. It's extraordinarily expensive to actually just purchase. It's a black box. Kaiser does not want to release that, so we're trying to understand how it is that we create the acuity modifiers. I'm then paid at 15% of the fee-for-service amount when I actually see the patient. And this is one of the challenges, because if you spent your time on the phone or on emails, you're not rewarded at the same level, although the amount that you're paid per day is pretty marginal. In terms of the rostered numbers, yeah, this is absolutely one of the complaints. It's great, I can roster 5,000 patients and I don't provide any access to my patients, but here I am being paid well. The government actually has moved towards capping the numbers. The numbers, you start to see a reduction for every 500 patients over 2,500 patients. This is a bit of an issue in some of the rural areas where there are 2 or 3 doctors and 6,000 patients. And again, I suspect it's similarly to Alberta. We probably don't have a problem with our total number of family physicians in Ontario. We have a problem with distribution. So as always, we have an oversupply of family physicians in our urban center and an undersupply in our rural communities. And our patient care groups moved some way to trying to address that.
So just a very quick volley for the last question, and then there's time later.
Yeah, sure. Rob Davies, physician in Calgary. My question has to do with the electronic health records that you use in these defined patient care groups. Would all of the physician providers in those care group kind of settings, would they be using an EHR, and what kind of sticks and carrots were put into play to get to that level of compliance? That's an issue we have in Alberta. A lot of these innovations depend on using an EMR effectively and having it universally available to the providers, but we seem to be a long way away from that still.
Yeah, so 2 quick comments on that. The first is that if you wanted to be a member of one of our alphabet soup models, our fruit baskets, our FINs, our FOs, our FIGs, you had to use one of the certified EMRs. So you couldn't actually be a part of that group, which is a slightly higher payment model than if you didn't. So you had to use that model, or you had to use one of those EMRs. And you had to use one of the certified ones that has access to the government, either the patient labs, the hospital report managers, et cetera, et cetera. One of our challenges in Canada is the United States in some ways has already figured this out. If you are IHE compliant in the United States, your EMR will talk to one another. And while a number of the EMRs in Canada have their IHE certification, we actually haven't required them at a government level to talk to one another. And that's one of those levers that the government has, certainly in Ontario, that they could apply that would ensure that we were able to speak to one another and then to our specialty colleagues.